Today, we welcome more than 300 colleagues who registered and who will follow this webinar either synchronous or asynchronous. 300 people who registered from more than 50 countries. So this is not anymore the Swiss Implantation Science Network. This has really become an international group of colleagues who are interested in implantation science. The reason that we had such a major response from all over the world is certainly linked with the topic today, which is the presentation of the Consolidated Framework for Implantation Research. And this is a framework that is being used for guiding contextual analysis, the foundational phase of implantation science. And also, of course, because of the esteemed colleagues who will present today. And it is absolutely a great honor and a privilege to welcome Dr. Damschroder and Dr. Rogal in this last webinar of 2023. Some words on the background of Dr. Damschroder and Dr. Rogal. So Dr. Damschroder, for those of you who are already working in implantation science, this name is very renowned. I think she's one of the most known implantation researchers in the world. Dr. Damschroder has retired as a full-time investigator with the Veterans Affairs Center for Clinical Management Research in Ann Arbor in Michigan, and this after 21 years, and has also retired as adjunct associate professor at Queensland University of Technology in Brisbane in Australia. Dr. Damschroder is really the person who has led the development and elaboration of the Consolidated Framework for Implantation Research. And this framework was recently updated in 2022, a publication in Implantation Science. And so today, the overview will be given from the development of the CFIR framework, as well as some information on the updates being done in 2022. Dr. Damschroder is really renowned worldwide and shown by the fact that she has lectured in a lot of countries, has been part of several research projects internationally, has led national workshops, and also, and this I think is also extremely important, has mentored many early career implantation researchers. And she continues to mentor and publish, and we are very, very glad she's today with us. We also welcome Dr. Shari Rogal, and Dr. Rogal is an associate professor in the departments of medicine and surgery at the University of Pittsburgh. She's the co-director of IMPACT, but not IMPACT in Switzerland, IMPACT in Pittsburgh, and the implantation lab course at Pitt's Clinical and Translational Science Institute, and the co-investigator and staff transplant hepatologist at the VA in Pittsburgh healthcare system. Dr. Rogal is a Pittsburgh native and has research interests which include liver transplant outcomes with a focus on addiction and pain in patients with chronic liver disease. And she's also passionate about using implantation science to address health disparities. So absolutely a great honor, a great privilege to welcome both of you here in our IMPACT webinar series. As said, today the topic is the CFIR framework, the Consolidated Framework for Implantation Research, updates and application. And before I give the floor to Dr. Damschroder and Dr. Rogal, I just would like to say that you're all welcome during the presentation to add comments, remarks in the chat function. There are no silly questions. What pops up might also be questions that are in the head of other participants. And so we really welcome a broad discussion. Because of this large interest in this webinar, it also means that we will have different levels of expertise in implantation science, and we welcome questions of those who are just starting, questions of those who have already much more expertise, and this will be the basis for discussion after the lecture. There will also be some polls. So with this being said, now really the time to give the floor to Dr. Damschroder and Dr. Rogal.
Thank you so much for that introduction. I am going to share my screen. I am sending greetings to you all from actually from a little town in Michigan called Chelsea. And it is morning here. I know that it may be night and evening or afternoon for others on this call. Shari gives greetings from Pittsburgh, Pennsylvania. And it's late morning for both of us. One thing that I just want to clarify is that I do not have a PhD. I don't qualify for the doctor title. I come to this work really, and I think that has kind of freed me to have a foot in both worlds, because before coming in as an embedded researcher within the Veterans Affairs system, which is the largest integrated healthcare system within
Laura, I think you're muted.
you. So you missed all of that.
No,
right.
We heard you up until you said that the VA was the largest integrated healthcare system in the US.
Interesting. All right, good. All right, thank you. So yes, largest healthcare system within the United States, which really has given tremendous opportunity for really, I give credit to the VA for their leadership and their foresight in really deeply and hugely influencing this whole field that we are now calling implementation science. And I wanted to say that, and with my background, I had 15 years worth of experience in, kind of the real world or out in the private sector, including 10 years of management consulting. Working with organizations to overcome barriers and challenges. I also worked in multiple organizations that started off very small when I started and were order of magnitude larger when I left. And so I've lived firsthand the changes and evolutions and challenges that organizations face. And in most of my positions, I was fortunate to be able to, have kind of a leadership role in helping to identify and, strategize to overcome and kind of develop as an organization, as an effective, high quality organization. So I think I share that just to share a little bit about myself, about for me, I have the, I guess the freedom, I've always felt the freedom in managing that tension between the rigor required in research and yet being practical and really understanding, I think, and empathizing with the people on the front line who are dealing with all of the day-to-day struggles and challenges. And then we come to the door and say, we've got this wonderful new thing that's really going to improve life and outcomes for your patients. And understand, and really understanding the challenges that even good change is challenging change. And there's natural, kind of it's human nature to resist change because it's hard to get out of routines and it's hard to get out of things that we're already familiar with. Anyway, I could go on, but that is kind of the heart from which I've always come from in doing my work. And to be honest, the Consolidated Framework for Implementation Research I was fortunate to step into a group, a team, really at that time led by Julie Lowry, a wonderful colleague and mentor of mine over the decades, who really came up that it was her brainchild to create like a one-stop shop of all of these concepts, because we were all struggling to know, what does it mean to really focus on implementation? What are the variables that we need to pay attention to, the concepts that we need to pay attention to? And at that time, there was just, it was kind of like the Wild West, we would say here in the US, meaning that anything goes, it's all new. But we were using different terms and different words and had different opinions. And so at that time, we were trying to gather all of the best in research that we could find from a conceptual level and bring it all into one place so that we could start speaking the same language. It was also a way, frankly, for us to learn. This is a product of our self-learning through this. And we drew from many different scientific disciplines. And so we really stand on the shoulders of giants, of other people in sociology, psychology, organizational development, business, who did this work before implementation science became a thing. So today I'm going to introduce the CFIR. Some of you may not be as familiar with the CFIR, but as was already said, it's been a very influential framework. And I will just say that it did not become influential out of advocacy. We developed this and then we moved on to other work, but it really kind of got traction on its own because I think it resonates with so many people. And it also came out at a time when everyone was struggling, just like we were, on how to get our arms around the complexities of implementation. And at this stage, I would like to do a poll. Julian, if you can bring up the poll, because we'd like to understand the degree of familiarity that people have with the CFIR, and then I can kind of tailor my comments based on that. Do I need to stop sharing or, oh, here it is, the poll. So the question is, how familiar are you with the CFIR? You can say you've never heard of it. There are a few people who are saying that. Well, I've read about the CFIR, so there's a number of you so far who, it looks like the majority right now, 2/3 maybe, the responses are still coming, who have read about the CFIR, but who have not yet applied it. So we've got about a quarter of the people on this call who have used the CFIR in a project. And then we have a handful of people who have used the CFIR in multiple projects. And you can take the poll down now, and we'll do a second one later. So thank you very much for answering that. So I will, given that most of you have just a beginning familiarity with the CFIR, I will really present this as kind of a holistic framework. I will do some highlights of the update, and in a few minutes we'll ask about familiarity with the updated CFIR. So to set the stage for the CFIR, what does it mean when we're assessing context, and why is that so important? First, a bit of history. This is actually a model or kind of a conceptual diagram coming out of what used to be called the Institute of Medicine, and then elaborated further by Enola Proctor and colleagues, where that really highlights that in the old days, we did a lot of current clinical trials, and we still do, that really focus on the what, like what works. And I'll say what works in ideal circumstances. where we have very tight criteria for the patients who participate, and we have highly trained research teams that are delivering a new practice, a new innovation of some sort. And so these trials are run under pretty ideal circumstances and controlled circumstances, although not as controlled often as we would wish. And then our focus is on patient outcomes. You know, of course, we're doing this work because we want to have positive impact on the patients that we serve. So this is the usual, you know, kind of pipeline, so to speak, or the usual focus that we have. And to do that work, we're really focused on internal validity. Is it really the practice that is creating these ultimate patient outcomes? But we really need to understand, if we want to get beyond just running trial after trial that gets published in journals that then get put on the shelf, and you know, many of you have probably, you know, there are authors many years ago that estimated it takes 14 years, and I would say sometimes it takes forever to get a new ideal practice or best practice out into the field so that it is routinely used in clinical practice as an optimal strategy. So we need to understand the strategies to get that out into the field, into clinical use everywhere. And to do that, we need to pay attention to more distal or more proximal outcomes. In other words, outcomes that are specific to the delivery. So there are all kinds of issues with how to get clinics organized or systems organized to deliver this new thing. And we look at things like the feasibility of getting that new thing in. Can they deliver it with fidelity and high quality? Can we get everyone in a system to deliver it? These are outcomes that are very important for implementation and assessing our progress to getting something new used in a routine basis. We also want to pay attention to what are called service outcomes from a system level. So all of these boxes in the inner part are within the domain of implementation science. And we know that this work is all being done within context that has many different variables that affect our ability to be successful. So getting to the CFIR, the CFIR offers a systematic way. It offers a standardized language and terminology for assessing context. So we entered into, and I'm going to talk about a little bit about the update of the framework for those of you who have been familiar with the original version of the CFIR. And very quickly, I'd like to do a poll. So if you can bring up the second poll that asks whether or the degree to which you're familiar about the update to the CFIR. And it'll be interesting to see this because maybe the update is your first introduction to the CFIR. So maybe you've read or skimmed the articles that describe the updates, or this is your first time. So it looks like it's looking fairly even. Either the first time, the majority of people, this is the first time hearing about updates, which that makes sense because the majority of people are not terribly familiar with even the original version of the CFIR, which is great. That's fine. This is the place to be. And then we've got about a little over a third of people, 36%, 37%, who have read or skimmed the articles that describe the update to the framework. And there are 21% of you who say that you have started using the new updated CFIR. The first thing we encountered in our process of updating the framework is that the requests that we got from users, some of them, some users wanted to have a new domain to capture outcomes. But we wanted to emphasize that capturing outcomes is actually outside the domain of the CFIR, because the CFIR is designed to identify factors or determinants that affect outcomes. So you as an implementer or an evaluator or a researcher, you can come to the table. You may be coming to the table with any number or any of a wide array of different outcomes that are important for you and your work. So we wanted to make clear, kind of differentiate outcomes and then categorize different types of outcomes, because there was also a lot of conflation between outcomes that are important to assess effectiveness of implementation versus effectiveness of the innovation or the practice itself, which usually is assessed in terms of patient level outcomes. Throughout this presentation, I'm going to use a case study that was based on a large pilot of a telephone lifestyle coaching program. And I'm not going to go into a lot of details about it. I'll tell you a little bit more about it in a few minutes. But basically, let's just say that the thing, so this is I love this article by Jeff Curran, who talks about, just really kind of, let's get the language down. It could be a practice, it could be a treatment, it could be a device, it could be a new medication. Whatever the thing is that we're implementing, it's important to understand what is that thing versus what are the implementation activities that we need to do to get the thing used in the right way by clinicians or by anyone involved with making delivery successful. So outcomes, the first thing we wanted to do was to highlight different constituencies, 3 major areas of constituents. In other words, of people who might benefit or who definitely are influenced or will influence our success in implementation. The first constituency or the first group of people that we really need to pay attention to, and I would argue that we don't pay enough attention to, are the key, I just call them the key decision makers. These are, you can imagine these as being the executives who make funding decisions. They're the ones who are very influential within systems on priorities, about priorities. So everyone may say, oh, it's so important to do better, for our patients. But in reality, if it costs too much, they're really not going to put their muscle behind it. So they may be concerned about cost reduction. They may be concerned about return on investment. The second constituency or group of people that we really need to pay attention to when we're working on implementing a new program are the people who are delivering that program. It can include clerks, housekeeping. We tend to focus on clinicians, doctors, nurses. It could be technical aides. Don't overlook. And with this new updated version of the CFIR, we really try to amplify and emphasize the importance of looking at opportunities to involve people that we haven't traditionally involved. But people involved in delivery, they would care about time savings. They would care about strategies. If we can bring strategies to the table that help to reduce burnout, that help. And then, of course, we care about our patient outcomes as well, clinical outcomes. And then the third constituent, which are trials typically, clinical trials typically, or focus on, are the outcomes, patient outcomes. And one of the things that we've done in the new updated version of the CFIR is to generalize terms. So deliverers include doctors within a healthcare setting. It could include teachers within an education setting. We've had the CFIR applied in farming. I'm collaborating on a new project that is applying the CFIR to museums. to strategies to get a more diverse population of people visiting museums. And then recipients include everyone. It could be students within a school setting. It could be, of course, patients within healthcare. In this talk, I'll keep it to healthcare because I suspect that most of you are working within healthcare. So moving on, the CFIR, so we have different types of outcomes. And the case study, case illustration that I'll use, the TLC coaching system, our implementation outcome was the rate of referrals. So in other words, the very first step in implementing this coaching program was just getting clinicians to refer patients, appropriate patients, to the program. So that was our kind of proximal, our outcome that it was most tightly linked to our implementation efforts. And so we categorize these outcomes in terms of actual or in terms of anticipated. A common example of what we refer to as anticipated outcomes is the concept of sustainability. We want to do implementation in a way that is sustainable. And so we might ask questions, how sustainable is this? How likely is it that you'll continue doing this even when our research funding, our implementation funding ends? And then actual outcomes are, of course, what's actually going on. So are you using it? Are you referring patients? And then the idea is that these outcomes are on the pathway to ultimately these the outcomes across the three constituencies. The CFIR itself is focused on identifying implementation determinants. What are the factors or what are the barriers and facilitators that impact these outcomes? So looking at this another way, within implementation science, we have kind of this meta theory that we're all working with. And the idea is that we have this thing that we want to implement. We want everyone to use it appropriately, and for every patient that would benefit from that thing, that program, that treatment, that they would actually receive it. But we also understand that there's a complicated implementation process that is required to get that thing into practice. And only by having an effective implementation can we get optimal implementation outcomes. And then ultimately outcomes for our three key groups of people. But all of this is happening within a multi-level context. So we have factors within the outer setting, which are, maybe system level or country level. We have factors within the inner setting, which includes the clinic or a hospital unit or a classroom in a school. And then we've got the individuals that are working within this multi-layer context. And context influences everything. It's both a moderator and a direct influence on outcomes. So our basic research question that drives use of the CFIR is, what are barriers and facilitators to implementation? This is our core question, because if we understand what those barriers and facilitators are, then we can design strategies to address those and optimize them for success. So our second, and this really is the meat of the work that we did to update the CFIR, was also published in 2022. And both of these papers, the one we call the first one, our outcomes addendum paper, and then the second one, which presents the framework itself, are published in Implementation Science Journal. So our process was, first of all, we received a lot of feedback. Our intent was not to do another theoretical sweep of all of the concepts from all of the hundreds of frameworks that have been developed since 2009. Our intent with this update was to go to actual users of the CFIR, because we wanted to improve the framework based on their experience using the framework. We wanted to be very practical about use of the framework and improve it based on users. So, but we did a systematic review and identified 376 articles, and this is out of almost 10,000 articles that reference the CFIR, but only 376 actually applied the CFIR in a meaningful way. It's not enough just to say we did the CFIR and then it's never mentioned again. 59 of those articles included feedback, specific feedback on the CFIR. And I just want to make a plug here that it's really important to critique the theories that you're using in your work, because that's how theories advance. That's how they develop and improve over time. 40%, so then we reached out to authors and we sent a survey to all of the authors of these 59 articles, or more than 59 articles, sorry, to all of the 376 articles, because we wanted more in-depth feedback. And we got 40% response rate from those authors. And one set of questions that we asked were an array of questions about applicability, usability, simplicity, and most of the ratings were quite positive, although a lot of users thought that the framework was complex, which there's not surprising. Themes related to the CFIR updates, or the based on the feedback of users, is that, first of all, we made the language that defined each of the constructs, each of the determinants, more consistent. And so we created, first of all, we want to emphasize that the CFIR is most of the time used to guide qualitative research. There is a lot of work afoot, but we're still in the very beginning stages of creating quantitative measures based on the CFIR. But most of the work is qualitative. And we really take an interpretive approach to context assessment, in large part because of the complexity of what we're studying. And in the original version of the CFIR, we were not consistent in how we defined the concepts, but in the new CFIR, all of the definitions of each of the factors or the constructs within the framework are arranged so that we can ask either qualitatively or quantitatively the degree to which each of those constructs manifests within your setting that you're doing the implementation. So, for example, people's perception of the evidence base for the innovation is influential. If I don't think it's going to work and I don't believe the evidence, I'm probably not going to spend a lot of effort trying to implement it, for example. So then we would ask the question of, and would want to know the degree to which the innovation has robust evidence supporting its effectiveness from the perspective of the delivery system. Additional themes is that we amplify the voices of people. The CFIR has always been defined, and this is based on kind of a keyword analysis of articles that cite the CFIR. And I found it fascinating, and actually I was thrilled to see that humans are at the very center. So that was even with the original version of the CFIR, but I will highlight ways that we kind of bring people to the fore more explicitly within the updated CFIR. We also have more intentional links to engagement, equity, and policy. So going back to our generalized theory diagram, within the implementation process, it's important to engage as many people who would be involved or have influence as possible in implementation, because then this helps people to buy in and take ownership for success. We also emphasize the importance of paying attention to equity. Let's implement new practices, new things in a way that helps to improve equity within the system and among patients. And then we also we expanded concepts related to the policy level that impact our implementation efforts. And then we also push users to more sharply define all of the 5 domains within the CFIR. So just to give a quick overview of the CFIR, especially for those of you not familiar with it, I already spoke earlier about the multi-level nature of the reality within which we're doing our implementations. And the first source of potential barriers and facilitators are around the innovation itself. And we need to define what that innovation is. Is it an electronic device? Is it a behavior change? Is it a medication? And then we also have factors related to the individuals themselves. You know, who are the individuals most likely to influence or have authority? Who will deliver? And then we have factors, barriers, facilitators coming from the inner setting. And this is really where the meat, the most of the work is going on, and many of the most impactful barriers are coming from the inner setting, coming from the clinic. We need to define where the implementation will occur. Is it in a primary care setting? Is it in a community-based setting? And to help answer this question, asking where will it be delivered? Where will the thing be delivered? And then the outer setting is harder to define, but what's important is to define the interface between the inner and the outer setting. So if we're talking about a primary care clinic, the outer setting may include the system within which the clinic is a part. It could be state level regulations, country level regulations. Those are all factors that come in from the outer setting. And typically we have much less control over those factors, but we need to know what they are so that we can work around them or within them. And then the last domain is the process domain. These comprise the actions or the methods that are used to actually implement. So the first domain, I'm going to dig in a little bit more about starting with the innovation domain. And one thing about the innovation, it doesn't have to be new to us or to the world necessarily, but typically it is new to the organization themselves, or they're really struggling with delivering the innovation. So we need to identify gaps in practice and try to close the gaps. Any of those situations are ripe for our efforts to implement. And in the case of the telephone lifestyle coaching program, this is just a high-level definition, but the more details that we can get about what are all the different components of the innovation. And for example, with the telephone lifestyle coaching, this was a behavior change program for patients. There were 6 optional modules, which I'm not going to get into because it's not important today. Participants received over up to 10 coaching calls over a 6-month period. There was a centralized coaching center. So the individual clinics that were doing the referrals, they didn't have to actually deliver the program. They just needed to refer patients to a program that was being delivered outside the clinic. So on the surface, it seemed really simple, and yet there was a 7-fold difference in the number of referrals, the rate of referrals between the sites that participated in this pilot. So within the innovation domain, we want to understand people's perceptions of characteristics of the innovation, but these aren't the typical characteristics like, okay, this is behavior change, we're using motivational interviewing, or we have a Fitbit, device to monitor physical activity. Those need to be defined at the domain level. These are more, what are perceptions of the evidence, which I already talked about. What is the perception of the advantage of implementing this versus something else that we're already using or another option that we're not implementing? So those are that is the innovation domain. And I think you can understand, how factors or perceptions about the innovation itself can influence implementation. The second domain is related to individuals. And we have in the updated CFIR, we significantly redesigned the domain. If you're not used to the original version of the CFIR, you're lucky because you won't have to unlearn. But we created two subdomains within this domain. First of all, we need to identify the roles, all of the roles that are involved in implementation or in delivering the innovation. And this includes leaders, organizational or system level leaders, high level versus mid-level leaders, also less formal leaders, opinion leaders. And then we have people who are involved in implementation. In the updated version of the CFIR, we put more emphasis on teams and the importance of teams. We want to move away from what I call the hero model of implementation, where we may have one really enthusiastic nurse who wants to get this implemented, but what happens when she either moves on or gets promoted or goes away, then everything falls apart when we're relying on a single person. So we really want the ability to form teams and with an identified leader. And then there are the deliverers and the recipients. So these are, we want to, like I said earlier, involve clinicians who are involved with delivering, but then also don't forget about the clerks, maybe housekeeping, other people who are involved that we don't often think about. And then we need to understand the characteristics of each of these individuals. And we chose these particular ideas, the needs for the individuals. So for example, if there are deficits, that maybe a clinician doesn't, already isn't able to do full record, episode documentation or encounter documentation, is there a way that we can shorten or streamline documentation requirements as a part of our implementation strategy? But paying attention to the needs of the individuals involved is just one example. In the case of our TLC program, our illustrative case, we identified all of these different people, which again, I'm not going to go into detail. The emphasis here is more that there are a lot of people involved, and we need to pay attention to their role and what their influence and authority is over implementation. And that's going to vary by setting. So if we're working with maybe 4 different clinics, you're going to have 4 different arrays of people who have influence or authority over implementation or delivery. So the next domain is the inner setting. And the inner setting is basically defining clearly, we need to define clearly where the innovation, where the thing is being delivered. And again, we emphasize, we highlight that individuals are working or embedded within the inner setting, within a clinic, for example. And then these are the different constructs that we have within a clinic setting, a hospital unit, for example. I'll go over a little bit of detail, but for example, one of my favorite, I have a lot of favorite constructs, but one of them is relational connections. This is really important. It's complex to assess, but very important. This is, what are the professional relationships, especially across organizational boundaries? Can people work together? To what degree is there a sense of teamness? Like we're working together to get stuff done. To what extent does that already exist before we come in and try to implement a new program? And you can imagine that in a setting where people are working together regularly, that might be an easier implementation experience than places where people are very isolated, or communications are very poor between units and professions, for example. Some of the expansions that we did in the new updated CFIR, and I'm just going to highlight these just to give you a better idea of some of the factors that are defined within the CFIR, are what we call structural characteristics. And a really common one is related to information technology, especially the electronic health record system. So if the EHR doesn't support a new process that is needed for the new innovation, that is going to be a major barrier. So that tells us that we need to involve computer and IT people to help modify the EHR if it's modifiable. But we need to know that going in, because we certainly don't want to hit that brick wall after the fact. A few other things in terms of culture. One way that we've really highlighted people and humans in this whole process is that we want to, and these are opportunities too, to address equity issues, potential equity issues within the organization, within the inner setting, by looking at, to what extent is the culture focused on human equality or patient-centered? To what extent are they patient-centered or learning-centered? And then we expanded, of course, having the resources available to do the work is really fundamental. We need to have the funding, the space, and the equipment available to do, to both implement and deliver. The next source of, in the inner setting, so for our TLC example, it included medical centers within Veterans Affairs. So this is within the large integrated system. And there were 25 of these medical centers who participated in the pilot. And then the next domain, the fourth domain, is the outer setting. And we significantly, well, first of all, I'll just highlight the outer setting are things that are coming in outside of what we defined as the inner setting. So for example, if we've got a medical center, in the case of our TLC pilot, the outer setting begins with the overall system. So there are policies and procedures, maybe performance management goals that are given by the system outside of the control of people inside the inner setting, and yet they're severely impacted, sometimes severely impacted by it. So this is the list of the different types of factors that we have within the CFIR, and just to highlight for those of you interested in what the update differences are. We added the stuff in the hot pink color, our additional constructs, so you can see that it's expanded quite a bit. And the ones in the kind of the yellow gold color are the ones where we change the name, but the definition is still very similar. We went away from, for example, cosmopolitanism, which frankly, I thought was a pretty cool word, but it just doesn't mean anything to anyone. So we changed that to partnerships and connections. So for example, if you have a contract in place to provide IT services that may affect my ability to implement something inside the clinic, I need to know about that. And so this is kind of highlighting the redesign of this domain for those of you interested in the differences. I'm not going to spend time on that. The next domain is related to the implementation process itself. So this has been significantly expanded. For those of you, and I have a swirl in the middle because, and then these arrows on the outside represent the constructs or the concepts that are in this domain. And what we want to know, for example, planning. To what degree is planning or did planning take place? And maybe you won't be surprised, but I'll just say that it is surprising how little planning occurs typically, at least in the projects that I've done. There is a paper led by Tom Waltz and Byron Powell and colleagues that defined a list of defined implementation strategies. And we've added some of those key strategies to the implementation process domain in the CFIR, but not all of them because there are 73 or 82 or something like that, way too many to include in the framework. So we encourage users in this domain and in all domains to add additional constructs and just be clear about what's being added. So you can see here that we've tagged many of these constructs are new. One of the constructs that we've added is teaming. So again, the importance of teams, the importance of assessing needs and context, tailoring strategies, so identifying and tailoring implementation strategies, and then adaptation or adapting both the innovation and strategies for successful innovation. And for those of you familiar with the older version of the CFIR, we removed 3 constructs, or actually all of the constructs related to individual roles that used to be under the engaging construct. And that all of these, so that all the individuals and the roles are defined now within the individual's domain, this second domain here. So that is an overview of the CFIR itself. And I know I'm over time, but I just want to say quickly, what do we do with this information? Within many of the projects that I've been a part of, we use mixed methods. So we use the CFIR constructs or the factors that are predefined, and we use it inductively. For those of you familiar with qualitative work, we use those definitions to code and analyze qualitative data. And then we quantify that data in many of our projects so that we can identify strong barriers, strong facilitators, weak barriers, weak facilitators, and we identify those by exploring the relationship between each of these constructs and the outcome of interest. In our case, it was referrals to the TLC program. So after going through this process, and if you look at the published TLC paper, which I'm happy to provide a copy of the slides, I do have a citation. But these are the constructs, 1, 2, 3, 4, 5, 6 constructs that were identified as being significantly linked to outcomes. And we contrasted the high referral sites, so the more successful, with the less successful sites, to kind of describe how each of these barriers or facilitators manifested in high versus low success sites. And then what we can do with these is that we do have a paper published, and this is based on the old version of the CFIR, where we asked implementation experts which of the implementation strategies that are listed in that earlier paper that I mentioned, which of those strategies would best address each of the CFIR barriers. So for example, if we have a barrier identified with kind of low quality relational connections. Used to be called networks and communications, and the new one, it's relational connections. Then the implementation strategies that we can use are network weaving and optimizing implementation teams. And there are definitions for these. I didn't know what network weaving meant, but basically it means to improve or optimize relationships between people. We do have a tool available, and we have a technical assistance website at cfirguide.org. And if you go under strategy design or under tools, you can find this implementation strategy selection tool that is based on the original version of the CFIR. We do have a version that people can use manually. It's a big matrix where we mapped the old CFIR to the new CFIR. I think I will leave it there. Basically, the next step, once we identify strategies, is to operationalize them. Who needs to do what and for what purpose, which are a very important step to go through. I also want to highlight that the article that was published presenting the updated CFIR, there is a crosswalk between the old and the new that is, and we have one, it's additional file 4 of 6 appendices that we have with this article. So the article itself kind of has an overview, and then there are all these 6 appendices that give a lot more detail. Thank you. And I know I went over, but we still have half an hour or more for questions. And hopefully there were things in chat to help get us started. As Dr. DeGeest said, there are every question is a good question. So please do not hesitate.
There are tons of questions, which is really great. So the first one, I can go in order, was how CFIR compared with evaluation frameworks like REAIM or PRISM for implementation of innovations and programs. So the differences and similarities between different frameworks, theories, models. And so so I recently gave a talk with the EPIS people and the REAIM PRISM people, and we started talking a lot about this. I would say that all three, and Laura, I'd love your insight into this as well. But REAIM is an evaluation framework, so it's much more similar to the CFIR outcomes addendum. So it's encouraging people to think about how they would measure implementation success or failure. And so it just gives you different definitions of how you can think about that, sort of similar to the outcomes addendum of the updated CFIR. Whereas PRISM is a determinants framework that focuses on the things that we think need to be in place for implementation to be successful. And so different people like different frameworks, models. There are frameworks that are very specific for certain things, like, tech specific ways of thinking about implementing tech. But the nice thing I think about CFIR is that, and PRISM as well, they're very content agnostic, and they're just thinking about, in general, what kinds of things need to be in place at these different levels to make sure that implementation goes well. Laura, do you want to add on to that?
Yeah, I think that, it can be a challenge, especially when you're new to the field, to really know how best to select a framework. And I think that, it definitely is a good idea to read about and become familiar with the most commonly used frameworks, at least at a minimum. And then assess for yourself which of the frameworks resonates most and applies most closely to the work that you're doing. You want to choose a framework that brings clarity to your work, not make it more complicated. The other thing that I'll just say about the CFIR compared to most of the other frameworks is that the CFIR is very agnostic to any particular theory. the main thing that the CFIR is bringing to the table is language and a way of separating out the different levels of factors. It's one way of looking at the world. It is not the only way of looking at the world. But other frameworks like PRISM, for example, or EPIS, for example, EPIS brings in ideas of phases of research. And that's something that the CFIR doesn't do. But we encourage, it's set up for users to create and develop their phases and conceptualize phases. But the EPIS has definitions for phases. The EPIS also kind of calls out different levels of management, leadership, organization. But often we combine use of the CFIR with other frameworks because the CFIR tends to be more operationalized. In other words, more specific definitions about each of the constructs. Whereas many of the other frameworks introduce, additional theories about why, or if I do A, then B will happen, guided by a framework. But the CFIR, you can combine that theory with specific definitions of constructs that apply from the CFIR.
All right. Next question is, contextual analysis is the foundational phase of implementation science, and CFIR is a most valuable framework to guide contextual analysis, but typically funding agencies don't cover the costs of contextual analysis. How do you deal with this challenge? What do you recommend to argue in a research proposal to also highlight the need for funding this? I'm throwing that to you first, Laura, and then
I was going to say, you want to take that?
Well,
we have struggled with that over the years, and I'll say that for my own work, I've gone from having to argue for and convince every PI I worked with in the early days, and I will just say that a huge sea change, a huge significant positive impact was Jeff Curran's and colleagues' paper on hybrid trials, hybrid effectiveness implementation trials. And they more recently, they have an update to these hybrid trials. So that we went from, my own experience was going from reviewers who questioned doing a formative evaluation as a part of like an AIM 3. And a formative evaluation is an evaluation that focuses on implementation, understanding the implementation challenges within the context of a clinical trial. And I just remember very clearly the first proposal that I recommended the PI put that AIM 3 as a formative evaluation. The reviewers pushed back and said, what the heck are you doing? This doesn't, you need to do a factor analysis or subgroup analyses. And so she had to rewrite the proposal. Fast forward now, another 15 years, let's say, if you don't have a formative evaluation as a part of an effectiveness trial, reviewers will often ask for it. More often than not, will ask for it, demand it. And I think that, part of this is just recognition that we need to be able to spend our research dollars in a way that have traction, that have a way forward from just doing that foundational research. And Shari, I don't know if you've got more specific, because it is, doing this mixed method work is more expensive than doing surveys and statistical analysis, which many of us are set up for.
Yeah, no, I mean, I think it's really helpful that people have generally accepted that implementation is actually an issue and why we're not getting to the outcomes that we're expecting with our intervention work. So I've definitely focused a lot on this concept of precision implementation, which is that it's not going to be a one size fits all. And if we don't understand the context, then we can't get to implementation. And so I've talked a lot more recently. People seem really excited about precision implementation, or the concept that Laura, you were talking about going from barriers to strategies. So I always sort of justify the fact that this is going to, where this is going and why it's so important. We've been working a lot on trying to make that process easier and more empirical. And so there was a question in the chat also about whether the ERIC CFIR tool is going to be updated. So I wanted to talk about that. We're really excited that we got funding to do Project Oasis, which is optimizing approaches to selecting implementation strategies, where we're going to build on the work that the ERIC and the CFIR group have done so well, of trying to map the new CFIR or updated CFIR 2.0, whatever you want to call it, constructs to strategies. And so we're working with all of the ERIC and CFIR people to do that in sort of a user-centered way. And we're also using a lot of data that we've been collecting from the US VA healthcare system over the last 10 years about which strategies were associated with better implementation across, the network of hospitals and clinics in the VA and a number of different healthcare issues. So stay tuned for that. We are very happy to partner with people on that because we really want to get a lot of people to think about this and work together on it so we can improve upon that tool and make it something that puts together data, expert opinion, as well as sort of the existing literature, which is quite vast. So if anyone's interested in that, we definitely want to hear more about it. The next question I know Caitlin loves this question, but I think I'm anticipating, Laura, you're going to love this too. Contexts are typically complex systems. Do you see the CFIR addressing this complexity? And how do you proceed to not only identify relevant barriers, yet also visualize interrelated dynamics between the relevant elements? Is it time to embrace system science methods more?
So I think there are multiple layers. In some of my presentation, I talk about different levels from where that contribute complexity. One of the levels that is very germane for using a framework like the CFIR are the fuzzy boundaries between what we're implementing, the thing that we're implementing versus the implementation approaches or strategies that we're using to get it into place. And that introduces complexity. So for example, especially when we're doing behavior change programming or, approach or things that are targeted toward employees, to make a better work experience or to increase their ability to deliver. Sometimes we focus on employees. So that's one source. The other, I guess the other thing that I'll say is, you're asking about relationships between constructs. We are encouraging people to move forward. So the CFIR is kind of like a sort of organized pile of bricks. You have these individual things, but we know that they're not influencing, they're not operating in isolation of each other. They very much influence each other. So for example, a leader's level of engagement or commitment will drive their priority, the relative priority. That's another construct that will drive available resources. That's another construct that may drive engaging or your ability to engage people. That's another construct. So we really need to do a relational coding and to and be explicit about building or highlighting those as advanced theories that draw on the definitions of constructs that the CFIR offers. So, I call it, kind of the box and arrow hypothesized models that are testable. We need to get there. We need to get to these hypothesized models of change. All the CFIR does is to try to help encourage people to be consistent in how we're defining and operationalizing the variables that are in those models, those hypothesized models. So using the CFIR to either develop measures that draw on the definitions within the CFIR, either quantitatively or qualitatively, developing those hypothesized models of change that, by the way, can be hierarchical interactions between policy level and microsystem level and individual level, communities, with clinics, definitely taking a systems approach to all of this. I feel like the CFIR is friendly to a systems approach, but you have to have that systems frame of mind when you approach using the CFIR. And I think that it would be valuable and it to write, to be just really clear, if you're bringing a systems science work to the table or perspective to the table using the CFIR, be really clear about that so that everyone else can learn and build from that. Because I think that's really important.
Yeah, and then we're getting some sort of interrelated questions that circle around the idea of how do you pick between all of these determinants and how do you pick which ones need to be addressed, which I think is a great question. I think I'm going to start and then you should just jump in and add on, Laura, but I think there's a couple of ways to approach it. I think sometimes when I talk with students who are learning about this, they feel like they need to include all. I actually was just looking back at the first grant where I wrote about CFIR, and I literally put the entire interview guide in as an appendix with every question, which of course you would never do. And so I think there are a couple ways to approach this. One way, easy-ish way is to really think about just asking really open-ish ended questions about what gets in the way, and then probing down more and coding with CFIR, but not necessarily asking about specific constructs, at least to start with. So I think that is nice, and that kind of gets at the way somebody was asking how you frame the CFIR determinants as questions that are kind of understandable for lay people. So you could just ask really open-ended or very, general questions and then code with CFIR. The other thing that I've done is getting sort of potential stakeholders or question answerers, people that exist in the context or users, to come together and do some almost human-centered design activities around picking potential constructs of importance, and then also ranking them in terms of both importance and impact, or changeability sometimes. So getting people to think through what you could actually impact, because maybe you don't ask about things that you can't ever hope to change, and you focus more on things that are perceived to be more changeable in that context. And we've been thinking about this a lot as we've been working on making a CFIR survey. How do we pick which constructs to ask about? So Laura, what would you add on to that?
Yeah, historically, we've suggested, there are three general ways to first of all, like Shari said, we don't recommend using, trying to evaluate every construct, but it is really important to include an open-ended question asking about implementation experiences or historical experience with doing other implementations to for that open-ended coding in case, in our process of narrowing down the constructs, we need to expand it or change it. For example, with that TLC pilot that I highlighted, we actually selected 12 different constructs that we were going to really focus in on based on interviews with our partners at the national level. And they had a lot of experience working with the program and had been working with individual sites in a prior smaller pilot. And we interviewed them basically and asked, for each of the constructs, how important are these? And we did that, probably took all of maybe 2 hours, 2 1-hour phone calls with them to get like importance rankings or ratings for each of the constructs. And we just used like a 1, 2, 3, really important, not important at all, or somewhere in the middle. And then we did initial interviews and we found that there were other constructs that were coming out in the interviews. And so we altered the list to prioritize. But we knew that we needed to alter because we had those more open-ended questions. And like Shari said, it's important to probe, we can ask about what do your leaders think? And they'll say, well, they don't really, they're not really committed to doing this. Well, tell us more, who, and, what do you mean? What are the behaviors? Exactly what's going on. And sometimes that opens up into other constructs. Another way to narrow it down are those hypothesized change models that I mentioned earlier that you've either developed based on earlier work or that have been published in the literature. And then another way is just, based on your own experience working within the system as well.
That is awesome. Somebody requested that you tell the story of how you went from the language around intervention to innovation.
Oh, interesting. I like that question. I've always had a problem with the word intervention because intervention just means to intervene. And it could be an implementation strategy is actually an intervention. A clinical intervention, of course, is an intervention, but the language, that ended up getting adopted over time is that anytime we say the word intervention, it means the clinical thing that we're trying to implement. Although it wasn't always clear because sometimes people would use intervention, the word intervention in a different way. So I've always personally liked Everett Rogers' definition of innovation, and it basically is anything new to the organization. So that really puts the onus of defining new on the organization, the people that are actually doing this. If it's new to them, and yet 90% of the rest of the world has been already using it, and it's not new to them. But if it's new where I am, the people that I'm working with, it's an innovation. So I just felt like, and it gets kind of tedious to say, well, it can be a device, it can be a pill, it can be a practice, a treatment. There are all these different words for the thing. So I like innovation and I like the thing because it just really clarifies the distinction between the targeted practice that we want to persist after we exit and after a focused implementation effort is done and people move on to the next thing. What are those components that we want to persist into? This is the way we do things.
And I really like this question from Petra, who asks, what role do the innovation recipients, like pupils or patients, play or have within the implementation process on the way to reaching different outcomes? Would this make
And
me think about, yeah, I don't know. Do you want to take
you
that one?
go.
No, I was just going to say that this makes me think about how a lot of times people will say that they want to do CFIR-based interviews with recipients or patients who are the intended recipients. And we had this conversation actually with the people who are using um, technology or trying to develop technologies that would be implementable. And so thinking about when you talk with end users, of course, they have to be involved and the thing has to be usable for them and it has to be not too complicated and it has to be, you know, cost effective or affordable for them. So there are, I think people sometimes think that those, because the language can be similar between intervention development and making the thing good for the people that are using it versus the CFIR, which is intended to focus on how to get the people in power or a position to implement to do the things necessary to get the thing to the users. So I think I still have, and then I also think about how it's really important and it can be and probably should be part of the implementation process to engage the end users and people, but all too often that doesn't happen. And so I think there's definitely a need for clarity about the role of the humans who will receive the innovation and where they fit into the CFIR. And I want to hear what you have to add to that, Laura.
Yeah, all that is so important, Shari. And I guess, you know, I have a couple of thoughts. One is the importance of involving patients or students into designing the implementation, which Shari mentioned, but I want to say it a little more concretely, maybe just to help bring it home. You know, it's interesting to me that redesigning clinical process is not a listed implementation strategy within the original published list of strategies. And yet almost every implementation we do involves redesign of work processes. So if you can imagine, I mean, imagine how important it might be to engage patients who are receiving this thing, the innovation, in helping to redesign that process in a way that is truly patient-centered. There are a lot of ways that we can get it done and check the box, but how can we do this in a way that's really patient-centered? And how can we make sure that it's patient-centered if we don't involve patients and really understand their experiences in this? So that's an argument for including patients, for example, in implementation teams, you know, that they would have a role explicitly in designing implementation. But I'll also just acknowledge that with these hybrid trials and with a push toward using human-centered design, user-centered design practices to, why not start developing the thing and the innovation and the implementation strategies together into an integrated bundle. And for that, you know, we must involve patients. And yeah, so, but that conceptually is a lot more complicated. But again, with our hybrid trials and our desire to accelerate the use of innovation in the real world, I think that we really need to push ourselves to move in that direction.
Yes. And all too often, patients can't really, unfortunately, contribute necessarily to a true like CFIR interview about what's going wrong in the hospital, because they may not know all of the behind the scenes part, but have a lot to say about the part that they're seeing. So, yeah. Okay, there's a lot of other questions. I don't know, Sabina, do you have one you wanted to prioritize in the last 5 minutes?
So I would say that here, perhaps the question of Kelly on the original cipher had a construct, knowledge and beliefs about intervention under the characteristics of individual's domain that has been removed. It sounds like you were describing individual perception as falling within the innovation domain in the revised version. What specific constructs within the revised innovation domain would you use to categorize individual perceptions, attitudes, beliefs about the value of the innovation, or would this still fall in the characteristics of a subdomain? And I think this is the last question we can address today. It's just fantastic, the reactions that came. So I give the floor to Laura and Shari to address this very thoughtful question.
I'm giving this to you, Laura. I have an idea, but I want to make sure that you agree.
Yeah, this was actually a source of debate for our team in updating, and it was generated because you're not the only one with this question. With the old version of the CFIR, users, based on the feedback that we got from users, a lot of people wanted to understand better the difference between coding for knowledge and attitudes, or knowledge and beliefs in the individual domain versus the perceptions in the innovation domain. So the innovation domain has first of all, I want to say that all of the constructs within the CFIR are eliciting perceptions of people. And honestly, you could double code most of what you hear from people as an individual level construct dynamic and or as a collective level dynamic. So for example, the relative advantage of the innovation, you could conceptualize that as their level of knowledge about the innovation relative to other stuff out there. But in the innovations domain, we're looking specifically for the perceptions about the relative advantage. So it's much more specific. This was identified by Everett Rogers in his diffusion of innovations theory, which is foundational. He's like a grandfather of implementation and dissemination. But I see knowledge and beliefs as a more general construct. The second thing I want to say is that the knowledge, and we didn't exactly drop knowledge and beliefs in the new version of the CFIR. I didn't go into this because so few people were familiar, with the CFIR already. But the new domain, the new individuals domain, and if you look in the papers and the additional files, we say a lot more and explain this a lot more. But that the choice of the capabilities, the opportunity, and the motivation, those three constructs, those are based on Susan Mickey and colleagues' COM-B meta theoretical model. And the COM-B is mapped to the theoretical domains framework that has over 70 different constructs across, 14 domains. So the new version of the CFIR expands the individual's domain by giving a portal into the theoretical domains framework, if that makes sense. So for example, knowledge and beliefs, or knowledge, is a theoretical domains individual level behavior change construct defined as a component of capability. And again, we say more about that in the published material that we have that makes that more clear, but that has not gone away.
So I look at the time, and unfortunately, we have to wrap up. I think we could continue for another half hour at least. And so I really wholeheartedly would like to thank both Damschroder and Shari Rogal for being with us today. This webinar will be available online for asynchronous viewing, and this will be on the Impact website. I truly hope that for the 2024 webinar series, we will have as much attention from implantation scientists and implantation clinicians all over the world. Truly, I must say today, this was an absolute highlight in our webinar series. We can't thank you enough. I think that we will also make sure that the papers will be available on our Impact website, as well as a PDF of the PowerPoint presentation, so that all have the opportunity to redigest and redigest and redigest the information, and of course then applying it. Because what we hope with this webinar series is that we inspire your implantation work. If you would like to be informed about what is happening in the Swiss Implantation Science Network in the coming year, register on our website, and we will really make sure that you have everything in time. So to wherever you are in the world, have a good rest of the day, have a good evening, and we absolutely are delighted for this kind of energy we felt today from our speakers and also from the audience.